of computer technologies, conquering space, and innovations in medicine. Modern education process requires continuous improvement support, including the scientific and practical qualification aspect. There is an urgent need of the independent side that will help professionals to get access to the innovative solutions in treatment. Eurasian Association of Therapists is absolutely unique global project, combining specialists from different countries and therapeutic areas, professionals that could get support to cure patients of therapeutical profile. It's a modern site that gives opportunity to the participants of Eurasian Medical Society the access to unique database and opportunity to share experience, share knowledge. The mission of association is to establish international medical research and educational project in between the countries of Europe, Asia, and CIS. Association carry out lots of educational events with the participation of leading experts, congresses, schools, conferences, telebridges, scientific agenda and curricula is done using modern educational methods and innovative formats. Today, association currently unites thousands of practitioners and experts from Russia, Europe, Asia, and CIS. It supports and helps to foster medical knowledge and daily experience. For us, it's important to make process of medical education continuous, modern, and very much accessible. Becoming the member of the association, you become the part of the global family of professionals working on the practical and scientific component of modern treatment. 10 seconds before the air. On air. Dear colleagues, good morning, good afternoon, and good evening. I would be extremely pleased if we have many participants today at our session, which is called Breakthrough Science of 2023. So that means very recent data, late breaking science of 2023. So different areas, therapy, cardiology, nephrology, gastroenterology, etc. Late breaking news. So I'm pretty sure that our symposium today that attracts lots of young specialist professionals, because it appears to be that I'm the most mature here, but nevertheless, I do hope that this symposium will be very interesting, very fruitful. And without any wasting of time, the first presentation would be made by Alexander Arutyunov, Relapsing Pericarditis, Breakthrough Innovations in Pathogenesis and Treatment. Mike is yours. Thank you very much. Thank you very much, dear colleagues. Well, I do hope that you can see my slides, and I will try to be very short because we are quite pressed for time. Today, I would like to share big data that we enjoy working with patients with pericarditis, especially with idiopathic, relapsing, recurrent pericarditis. But let's move step by step. This is my disclosure slide. First and foremost, let's look at the pericarditis as it is. Well, normally we have 25 milliliters of fluid, later than 25 in the pericardial envelope. But when we face pericarditis, it's obvious that we see a lot of fluid there, which is accumulating, and it's important to understand what could be the trigger to this process. Why does fluid accumulate? Well, definitely viruses, including COVID-19. That could be one of the reasons. Also bacterial pericarditis, which is not very frequent, also fungal, especially in HIV, parasitic, even more rare, but also autoimmune involvement with the current autoimmune autoimmune process, or it could be even idiopathic situation when we do not know the reason. This could be also metabolic, tumor-based, and also damage with chemotherapy. So that's a huge list that creates the damages of pericardium, and it's very important for us to understand that today we are separating acute pericarditis, relapse pericarditis, recurrent one with the known reason, and also idiopathic pericarditis with the unknown reason. So how many of them, you can ask me? A very good question. We don't know for sure. But these are very rare cases, single cases for thousands, for 100,000. This is a situation when we never ever know the reason of relapse. Why? Why can't we do that? Well, first of all, not everyone accepts pericardial biopsy because patients do not always accept that. And also the reason could go on, but autoimmune already launched, autoimmune process is still there, latent. We get pericarditis, we get patients with huge signs and symptoms, lots of complaints, and we need to do something about it. Let's move step by step. All these patients should be properly examined. It is clear that we look at the blood tests, we look at renal function. It's important because we need to start the treatment. And NSAIDs, non-steroid anti-inflammatory drugs, are relapsing. This is ECG, ECG, and sometimes X-ray. But in complicated cases, if we want to get correct diagnosis, avoid CT, like with myocarditis, CT and MRI, that's golden standard. Puncture, very preferable, very preferable. If you're looking for the viral reason, let's move on, because we speak about a relapsing idiopathic pericarditis. And unfortunately here, it is very difficult differential diagnosis. We should exclude diseases involving pericardium, also rare diagnosis. We should assess the clinical manifestation, the rate of relapse, regular monitoring of increasing high sensitivity C-reactive protein, and also echocardiography, which is a must. Also, we need to identify the prognosis. We know for sure that if the disease starts from fever, from acute onset, plus effusion, strong effusion, and, well, tamponade pericard, or no response to NSAIDs, so that's very poor prognosis for the patients, and preferably they will be very frequent relapses. Well, moderate myopericarditis, immunodeficiencies, post-traumatic pericarditis, and traumas with anticoagulants, both can lead to the negative outcomes. And also we should calculate the risks. We have very clear understanding. We ask the question, what we have examined, is it pericarditis? Yes or no? Yes or no? If not, pericarditis is not possible. If yes, etiology is known, then what could be the predictor of poor prognosis? And if it is so, hospitalization. But then we start extra examination, and also we'll look at the effect of NSAIDs. And majority of our patients with idiopathic will belong to the moderate risk. Hospitalization is preferable for extra diagnosis, for the confirmation, for the definitive diagnosis by exclusion. And then we select the treatment. And here is becoming most challenging. So we say that we start treatment of pericarditis, and everybody speaks about colchicine. Yes, systemic anti-inflammatory treatment, but there are some other options. It could be acetyl salicylic acid as an option, appreciate up to 4 grams per day. So that's a huge load, or very high doses of ibuprofen. We also have such data in the European Society guidelines, and there's a huge risk of acute kidney injury, AKJ. There are options of combination, colchicine plus NSAIDs. And there are some trials like this. But again, colchicine as one of adverse reactions has acute kidney injury, AKJ. Don't forget it. We control C-reactive protein. We provide bed regimen, and every week we assess the effect, whether effusion is gone, inflammation is gone, or pressure in the chest is gone or not. And only then, if all that is not effective, only then corticosteroid could be added. Where is the fourth line? The fourth line of treatment could be seen mainly for the relapsing forms of pericarditis. And the fourth line, this is pericardioectomy, but we missed another important block, which is the use of IV immunoglobulins. And IL-1 blockers, IL-1 interleukin-1 blockers, and that's the most interesting. Patients who face with idiopathic relapsing pericarditis after the first episodes, in 30% of the cases they go for relapse, 50% they go in the second relapse, and then there would be even more. So it's obvious that they become sustainable to colchicine plus risks. They are steroid dependent, and this is unresolved issue in the modern cardiology. It is obvious that they have very low quality of life, frequent rehospitalizations and referral for care, and all of them will have very difficult problems related to the negative effects of non-steroid anti-inflammatory treatment, at least in the long-term perspective. And we had enjoyed a very big presentation on that during the plenary session. So each half a year, they take at least one visit. So where do we expect the relapse? In those patients who are using glucocorticosteroids, in those who cannot get colchicine due to some reasons, and also those who have resistance to that, and also those who demonstrate the dose reduction for anti-inflammatory treatment until the normalization of C-reactive protein. What can we do? We can use maximum doses if we face a risk of adverse events. So we can regular control CRP, or we can refer to new methods related to the block of IL-1, and that's a breakthrough. That's a true breakthrough in the treatment. Yes, we used to have one block of IL-1, but now we are saying that the width of analysis, the number of publications is actually really incredible. It's a true breakthrough where we enjoy new options that help to block IL-1. Why NLRP3 here? It's inflammasome, which is activated by the viruses, lipids or hypoxia, and some other ways through caspase 1, through Pecard mechanism and caspase 1. It releases IL-1. And today the role of IL-1 and IL-B has no doubts about it. It's more than obvious that inflammasome of type 3, they could be type 1, type 9, type 12, but NLRP3 responsible for the release of IL-1, but you can make an objection. IL-1 is not sustainable, very difficult to measure, but nevertheless, it is possible. And there are such publications. We have very clear understanding when we block IL-1, we stop local and very severe autoimmune process, and then we will be able to stop the progression of pericarditis in these patients. So that's a key role of IL-1. It is proved, and it is obvious. The more options we have in the treatment of such people, so the better the result. So now I'm happy to introduce the first block of IL-1. So that's very intermediate result of the study. The study has not yet been finished, but this is late-breaking science. So in fact, what is in the trend, and all the presentations are like this, and this is original, absolutely original IL-1 blocker, which is bridging IL-1A and IL-1B, and it helps to reach the remission in a huge number of patients. That's a very big study which was carried out in these patients with idiopathic relapsing. So that's most life-threatening group, and they were included with the confirmed diagnosis based on criteria of European Society of Cardiology, GOF-LICITSEPT. So patients with relapses, without features of relapses, were included with the previous treatment. So that's not naive patients, not pretreated patients. It was split in between the groups, and they were getting different doses of GOF-LICITSEPT. They were followed for quite a time, and the results are hair-waving, really hair-waving. Please appreciate how it's changing in the patients, all patients, even patients with relapse symptoms changed. C-reactive protein drops down, high sensitivity C-reactive protein, and also how dramatically changes the situation with pericardial effusion by week 8. So block of IL-1 using new option, new treatment in this class helps us to reach really stunning results. And the most interesting, the relapses. What about the relapses? Let's appreciate in placebo group, placebo control. So relapse of pericarditis was seen in 8 out of 10 patients, but in GOF-LICITSEPT group, no relapse reported. So 8 out of 10 versus 0 relapse rate. So it's obvious that the use of GOF-LICITSEPT in fact led to the termination of the pathological process in idiopathic relapsing pericarditis. And you will ask the next question, what about safety? Because this is block of IL-1. We know lots of problems. So this is expected, class specific. And there were some infections events, mainly viral genesis, and they never led to the hospitalization or to the worsening of the condition of the patient. So we can speak about the absolutely new, very effective and very safe treatment, Gotlicizeptor, which is IL-1 blocker, that could be used in all the patients who have idiopathic relapsing pericarditis. And now, to all of you, I would like to say, please pay special attention to all the patients where we have a relapsing picture. If we cannot give clear etiology, yes, we can think, we can guess, but we may not know. So such patients should be referred to a very specialized care center. I know there are some centers in Russia, and specifically this is Almazov Institution or Chazov Cardiology Center. So these two sites, they are referring patients there. If it's the territory of other countries, in Yerevan, this is Teribuni Clinic in Kazakhstan. This is Almaty Cardiology Center and Astana Cardiology Center. And we should refer these patients there because we got a fantastic tool that allows us dramatically improve the quality of life of those who are, let's say, much lower than the threshold of the normal quality of life, much lower, and they are facing these relapses. Now, this fantastic tool is available, and now I invite all of you who listen to this presentation to find out more about this class of treatment, about this molecule, Gotlicizeptor, and start using it. We are quite pressed for time. With that, I finished my presentation, and I'm happy to give the microphone to our moderator, Professor Fomin. Alexander, thank you very much for a fantastic presentation. That's really very interesting beginning. I appreciated the list of presentations. Well, all of them are late-breaking sciences, many about inflammation. We understand very clearly the pathological process that continues now, is available now in the chronic diseases of other organs. In fact, it's a priority to all of us about so-called just a second. So-called diseases that are becoming chronic. That is why my presentation, which I'm making today, just a second, I'm trying to launch my slides. I already launched it, but we cannot appreciate your slides. Okay, we are waiting for the technical support team to help. So we have very clear understanding that the topic we are discussing now, post-COVID, we cannot see your presentation. Not so stuck. I'm really sorry about it. Can you see it now? Not yet. I have an apology to make. I will have to restart my computer. I think now it's getting better. Please try again. That is why in post-COVID, we will speak a lot. We're out of air. Colleagues, it's all very small and I cannot make it wider somehow. I don't know why. I will restart the computer, I'm sorry. Maybe you give the floor to the next speaker and then during the second presentation, you will have extra time to restart. Just a second. Now it's okay. We can enjoy your presentation. So 5 seconds and we go to air. And please start from the beginning. Ready. Just a second. We should go on air. 3, 2, 1. Distinguished colleagues, we do apologize for the technical challenge. Somehow I could not launch my presentation, although before that it was very nice. So I will shorten a little bit my speech. But today we will speak about post-COVID chronic heart failure, CHF. It's very logical. Any chronic or acute inflammation is a provocation of heart failure. And we will ask a question, how active could be this process? If we take data for 2021, so 1 year of COVID, and please appreciate here, there is a feeling that heart failure is quite massive. For example, about chances, 3.4. This is meta-analysis. Then meta-analysis becoming more aggressive, increases 12 times more what we have in the heart failure. Yes, that's quite an emotion. And as soon as we start speaking about 2022, this is article of December 2022. That's very logical situation. So hazard ratio is 199, so that means twice. And the most important, the incidence of heart failure, so no matter whether it's reduced, moderately reduced, or preserved ejection fraction, so in average, it's about from 0.9 up to 1.3, you will tell me, but this is not high, But if we speak about populational level of heart failure, from 1 to 2% up to 3 in Germany, this is heart failure with reduced ejection fraction, plus 40%, 50%. So that's about 2 to 6%. That's heart failure in total. So adding 1% is quite a lot. In this meta-analysis, where 21 million patients were including, and from them about 1,200,000 those who experienced COVID-19, only 2 stratification parameters were important and then increased the rate of heart failure. This is age and hypertension. But now American colleagues in 2022, they start talking on the fact that most probably patients that are creating heart failure post-COVID would be much younger. And this is significant. Please appreciate the odds ratio 1.5. That means 53% would have higher risk for youngest versus elderly ones. And the total risk of heart failure in post-COVID scenario is 45%. That's a very important moment. If we speak about the risk at populational level, then that's quite surprising situation. Again, we truly confirm the position that in average 0.81% of patients with CHF, and that data would be increasing. So when can we expect heart failure? Well, on average in 3 months, and we clearly see that according to our own data. And also in average, it looks like 1.4 patients per 100 patient years. So if COVID is not 2.5 but 5 years, so most probably we could expect the incidence and prevalence of 5 patients per 100 patient years. And if we speak about the risks, so it is extended representation of the positions. Only ischemic heart disease is not statistically important here for the creation of chronic heart failure, which is also a strategic factor. But it's very important if we look at the use of proper treatments here. So the classical of prevention are beta blockers, and the rest guides just the severity of the patients. We know for sure today, that patients who create chronic heart failure most frequently have arrhythmias, also atrial fibrillation, and in that case, we see normally 2 forms of heart failure. First, those who are classical one, who had classical disease, and we know for sure that those patients had COVID, and the others were in lockdown and unfortunately reduced dramatically physical activity. 2 strategic positions. First, the disease, COVID-19, and the second one, lockdown and no physical activity. Both are provocations. And if we look at the forms of CHF, we don't see any big differences according to the criteria. Speaking about the survival of the patients, so the third wave of COVID appeared to be the safest for Europe. And if we look at the current situation in Russia for wave 3, so that's sampling of patients that we followed in pre-COVID and in post-COVID period. So in pre-COVID, we have a high risk of heart failure and patients who were after decompensation, severe patients in the first wave. So these are the residual cases, and these are fatal outcome rates. That's the second position here. Then the red piece shown here. You see here that mortality is reducing because majority of severe patients already died. But we understand now that the second and the third wave were the most aggressive for the Russian Federation, and the fourth and the fifth one, although the incidence was high in the wave 4 and wave 5, but the risk of mortality started reducing, especially after wave 5. If we look at how patients are dying, so please appreciate here, in the first 100 days, it's a classical decompensation of heart failure. That's why COVID appeared to be criteria of decompensation of chronic heart failure. And later on, within the next 18 months, up to day 140, approximately like 1, 2, 3, 4 functional class, they have the same mortality here, because these are the most severe patients who already died. And then we see classical story after day 300 patients with functional class 3, 4, they start dying more actively. And what was shown here in 2 studies, that's a classical COVID study. Mortality risk in patients after COVID were increased in the cold period. That means in 100 days, they were twice higher, both in the South London study and also in the Danish study. Now we understand that survival of the patient is associated not only with the infection they survived, but also with so-called reduction of physical activity. That's very important. That's why there is a very good idea. Which patients could we see later on? What would be the portrait of the patient that we can face during second year after SARS-CoV-2? Mainly, if patient had mild form of COVID-19, they never refer to any hospitals, and patients used to have class 3, 4 functional class by NIHA, with a classical clinical manifestation with diastolic dysfunction that have CHF, have PEF within first 7 years with moderate tachycardia. And very important moment here, please appreciate dramatic increase of arterial hypertension and ventricular arrhythmias, a higher risk of acute coronary syndrome, and that is definitely association with COVID. Patients who had disease before with a severe form of COVID-19, and please appreciate it here again, class 3-4, functional class 3-4, with severe dysfunction of right ventricle, with a high risk of pulmonary artery thromboembolia, also with very complicated and very diverse arrhythmias, and also fast dilation, which is associated with diagnosed or non-diagnosed myocarditis. But the most interesting situation are asymptomatic patients, asymptomatic carriers of the infection, and they will create pain syndrome, pericardial pain syndrome, diastolic dysfunction, then have PEF, heart failure with preserved ejection fraction, plus hypotonia. So those patients that were somehow covered by COVID, those who had a mild form or who had a symptomatic course, they will have 3 possible you see they are shown here, and mainly CHF with thromboembolic complications. That's interesting publication of 2022. And Kanata called it SARS-CoV-1 infection with cardiac injury is equal to the Armageddon. So what do we understand by that? That those patients who had not very high risk of mortality, those who did but could be infective and subclinically have the disease will have very diverse manifestations. So we expect for the next 5 years, younger patients with heart failure, with very significant and very diverse clinical manifestation, but priority is definitely HFpEF. Thank you very much for your attention. And now we move to the next presentation. We move to the next presentation, which will be done by Azamat Baimukanov from Moscow City. He will speak about screening possibilities for diagnosis of sleep apnea in patients with supraventricular tachyarrhythmias. Supraventricular, we know that apnea could be the provocator of a very difficult ventricular disorders. So today we speak about supraventricular. And I have first question to ask them up. What about the risk? Can we increase life-threatening rate of tachyarrhythmias if there is supraventricular manifestation? You're welcome. Thank you very much, Professor Famin. Thank you very much for very kind invitation and representation. I will start from my presentation and then I will be happy to answer your question. Yes, let me introduce our project. I have to say that this is a very small piece of a very big project which is ongoing for the last year in the city clinical hospital named after Buyanov, where we examine patients with different arrhythmias, tachyarrhythmias. We performed radiofrequency ablations and also we follow respiratory sleep monitoring. It's not a secret. The most prevalent supraventricular tachyarrhythmias, both atrial fibrillation and atrial flutter. It is clearly say the figure is almost reaching 50 million patients a year. So this is the number of patients who reported atrial fibrillation. According to the latest data in our country, in Russia, we also see the increased incidence and prevalence with patients with atrial fibrillation. And actually all over the world, if the risk of fibrillation was 1 to 4, but now it's already 1 to 3. And that's for Caucasians older than 55. Caucasians 55 plus. Well, flutter, atrial flutter is quite relevant tachycardia as well. The prevalence is pretty high. And it's interesting that in males, this form of arrhythmia is diagnosed much more frequently versus females. It's not a secret that very frequently in patients with atrial fibrillation or flutter, we also diagnose the syndrome of obstructive sleep apnea. So our colleagues in their study showed that almost 87% of patients with atrial fibrillation with AF sleep apnea was seen, both moderate and severe. And also, there is a reversed link, which was proved with sleep heart rate study, that the prevalence of atrial fibrillation was higher in patients with obstructive sleep apnea. Why? Why it happens like this? First of all, it is related to the fact that we have so many common factors between these supraventricular tachyarrhythmias and the risk of sleep apnea. First of all, elderly age, obesity, hypertension, diabetes, smoking in the medical history, and also male gender. The objective of our study was to look at the prevalence of obstructive sleep apnea in patients in this group with these tachyarrhythmias, and also to look at the effectiveness of the questionnaires which are available and which are offered by modern medicine. In our study, we recruited 155 patients. From them, we selected the group 105 patients where fibrillation or flutter were diagnosed. The diagnosis was established. Also, in a fewer patients, we identified both fibrillation and flutter simultaneously. Then all patients enjoy standard laboratory and instrumental tests, including respiratory sleep monitoring, which is SomnoTouch. And also we enjoyed stop bank and APAT questionnaires. Among the patients with fibrillation and flutter of atria, the syndrome of obstructive sleep apnea was diagnosed almost in 70% of the patients, 70. Syndrome of obstructive sleep apnea, so-called SOSA. And actually, we didn't see any preferences within the severity rate, but as you see, mainly prevailing were the moderate and severe forms. We also carried out the comparison, patients with and without sleep apnea. We looked at demographic and laboratory data. We identify statistically significant difference in age, so that means patients with sleep apnea were older. Also, they had high BMI, bigger waist circumference and neck circumference, and also had lower GFR, estimated GFR. As I said before, currently there are very different questionnaires available to carry out screening diagnosis of syndrome of obstructive sleep apnea, SOSA. The most important task for them is to identify, because if you don't have any technical tools, but it helps you to suspect this problem in one specific patient. So Epworth scale, the insomnia Epworth scale, is very prevalent. It includes questions about the probability of sleeping in different situations during the day. So currently they believe that everything which is higher than a level, it's already higher than the normal level and requires consultation of the specialist. Then stop bank scale, also used for the probability of obstructive sleep apnea in the patients. And they consider that everything which is equal or higher than 3 or higher, that's the moderate risk of obstructive sleep apnea. And at this level, it's recommended to pay attention to symptoms and to carry out additional examination in the specialists. In our study, we got absolutely contradictory results, absolutely opposite results. According to Epworth scale, the high risk of apnea was identified only in 13 patients, 13 out of 105. And if you look at the same population, the stop bank, then we could suspect the obstructive sleep apnea syndrome in 91 patients. So stop bank appeared to be more effective. If we compare apnea rates among patients depending on stop bank data, we got statistically significant difference. And truly, the chance of sleep apnea in patients with 3 points or higher, according to stop bank, were increased 18 times. We also carried out the assessment of diagnostic significance of stop bank questionnaire when we predicted sleep apnea. The surface under the ROC curve was 0.87, and the model appeared to be statistically significant. At the same time, the threshold level in cutoff point appeared to be 2.5, which actually meets the recommended level by the authors of the questionnaire. With such number of points, let's say higher than 2.5, they could predict higher risk of SOSA, syndrome of obstructive sleep apnea, in patients with atrial flutter or atrial fibrillation. Well, the model had pretty high sensitivity, 98%, and relatively high specificity. So from here, we can clearly conclude that very frequently we can see obstructive apnea among the patients with atrial fibrillation and atrial flutter. The insomnia effort scale, unfortunately, is not the screening tool for the diagnosis of SOSA in patients from this specific group. Stop-Bank questionnaire demonstrated very high sensitivity and specificity to identify the risk of syndrome obstructive sleep apnea in patients with particular arrhythmias, supraventricular tachyarrhythmias. Thank you very much. Can we go back to the question? Could it be life-threatening from supraventricular? Could they be life-threatening? Yes, sure. Yes, sure. Especially early mornings. Very early morning hours are most dangerous for such patients. Thank you very much. And we move to the next presentation, which will be made by Kristina Kopyeva from Tomsk. She will speak about the adverse cardiovascular events in patients with coronary microvascular dysfunction, prognostic markers. You're welcome. Good morning, good afternoon, dear colleagues. I'm extremely happy to make my presentation today. I will make it full screen now. I'm extremely happy to make my presentation during the Congress. I have to say that this work was supported by the grants of the Russian Federation President. So what is the coronary microvascular dysfunction? This is a type of non-ischemic disease which could be independent pathology or could accompany different cardiovascular diseases. If we speak about cardiovascular diseases, so mainly this is heart failure with preserved ejection fraction, HFpEF. The increased number of publications is obvious. It speaks for the relevance of the topic. Back in 2022, in JAC, we enjoyed meta-analysis where more than 14,000 patients were recruited, and they showed that the percentage of coronary microvascular dysfunction in patients with ischemic heart disease reached 41%, and if patients had heart failure with preserved ejection fraction, HFpEF, then the prevalence is increased up to 85%. And also studies tell us that coronary microvascular dysfunction is the independent predictor for the development of severe cardiovascular complications, and it is measured through the reserve of coronary flow. The golden standard to assess the coronary flow reserve, this is positron PET or cardiac MRI, but this is very expensive and not highly prevalent in the real practice. That's why cardiology is not standing still. And one of the methods, perspective methods, is the dynamic one-photon emission tomography that also assess the CFR. So our objective was to look at the rate of adverse cardiovascular events in patients with non-obstructive microvascular dysfunctions that was diagnosed according to the dynamic SPECT for 12 months of follow versus patients without microvascular dysfunction. And we should identify prognostic markers that could influence the unfavorable outcomes in this cohort of patients. We included 118 patients with non-obstructive involvement with HFpEF, with sinus rhythm, that accepted to be recruited into the study. Exclusion criteria: MI in the medical history, revascularization or future revascularization, hypotension, hypertension, severe arrhythmias, valvular pathology, cardiomyopathies, or severe concomitant pathologies that could prevent recruitment and stress test. Dynamic SPECT was done according to the standard 2-day protocol. Vasodilating agent was adenosine 3-phosphate that was introduced for 4 minutes, and also except dynamic SPECT, we looked at standard perfusion and also myocardium scintigraphy. The reserve of coronary flow was identified from the reserve of main coronary arteries, and the reduction of less than 2 was the marker of coronary microvascular dysfunction. Echocardiography, standard protocol, diastolic dysfunction was assessed, and also global longitudinal deformation, biochemical analysis, biomarkers to get, let's say, a more precise picture about the pathogenesis of microvascular dysfunction, which was done by ELISA immunoassay. 6 patients drop off because no follow-up. So finally, we included 112 patients to the final analysis. We looked at a spectrum of biomarkers, fibrosis, inflammation, overstretching, and also depending on the presence of microvascular dysfunction, patients were split into 2 groups with CFR less and higher than 2. Then we followed them for 12 months prospectively and then had data analysis. According to the demographic characteristics, groups were very well balanced, except the fact that patients with microvascular dysfunction had diabetes more frequently. We more frequently diagnosed HFpEF, and also they were smokers more frequently. According to echocardiography data, patients with microvascular dysfunction, we had high levels of diastolic dysfunction and also the reduction of the global longitudinal deformation of the left ventricle. The standard perfusion scintigraphy of myocardium, no difference in between the groups. And in terms of flow, in patients with microcircular dysfunction, flow with ATP was lower, significantly lower, although at rest it was statistically higher. And the global flow reserve was significantly higher when we split patient according to the flow. Looking at biomarkers, patients with microvascular dysfunction showed higher level of natriuretic peptide, high level of pro-inflammatory biomarkers, and at the same time, anti-inflammatory biomarkers, IL-10, were significantly high in patients with microvascular dysfunction, and also markers of fibrosis, TIMP and MMPs, matrix metalloproteinase type 9, were high in patients with microvascular dysfunction. Titramectin, IL-6 were no different in between the groups. According to the result of correlation analysis, it was shown that flow reserve was related to natriuretic peptide with fibrosis markers, also parameters of diastolic dysfunction, and also pro-inflammatory and anti-inflammatory markers, as well as positive link was identified, very strong correlation with the GLS, global longitudinal deformity. So unfavorable cardiovascular events were reported during 12 months. Not many rigid endpoints because follow-up period was rather short. 1 sudden cardiac death. 5 patients were hospitalized because of HFpEF decompensation. The other were milder progression of heart failure. And also in 5 patients, heart failure was diagnosed de novo within this 12 months follow-up, and 80% of the patients did not have unfavorable outcomes. At the same time, when we carried out Kaplan-Meier analysis, we showed that in patients with microvascular dysfunction, the rate of events was higher versus patients without coronary dysfunction. This is one factor, one variance regression analysis. Such parameters are diabetes, heart failure, natriuretic peptide hyperexpression, C-reactive protein, diastolic dysfunction, smoking, and coronary microvascular dysfunctions were the predictors of unfavorable outcomes. When we carried out multifactorial regression analysis, we had independent predictors like coronary microcircular dysfunction, diastolic dysfunction, and their combination increased the risk of unfavorable outcomes almost 5 times. We explain such factors as predictors of unfavorable outcomes to the fact that the patients mainly had unfavorable outcomes related to the heart failure. That is why these factors appear to be quite significant in the prognostic model. And now about the limitations of the study. Well, small sampling, short follow-up, definitely we could not reach statistically significant parameters. We didn't have enough power for some rigid and soft endpoints. That's why endpoint was combined endpoint that unites both hard and soft endpoints. Conclusions. Coronary microvascular dysfunction was associated with a higher risk of unfavorable cardiovascular events. Combination of microvascular dysfunction with diastolic dysfunction increased the risk of unfavorable outcomes 5 times. And coronary microvascular dysfunction was associated with the parameters of diastolic dysfunction as well as markers of fibrosis and inflammation. Thank you very much for your attention. Christina, thank you very much. Crystal clear. What was the most significant trigger for microvascular dysfunction? What do you think what was most important? A septic inflammation, maybe volume-dependent injury of cardiomyocytes, fluid retention, because NT-proBNP was important here. What do you think? What was most significant? Thank you very much for the question, Professor Famin. NT-proBNP played because we had high rate of patients with CHF in group with microvascular dysfunction. But speaking about pathogenesis, we believe that most probably it's a septic inflammation because markers of inflammation were higher, although they were not higher than the reference level, but they were still significantly higher. So that means it's a chronic septic inflammation. That is the most important. So as soon as pain syndrome comes, then it could be acute coronary syndrome. Then we confirm this is microvascular angina, and then every other parameter will play. So we come to the next presentation, and this is our distinguished guest from Tbilisi. This is kidney injury in patients with COVID-19, and we are happy to give the floor to Sofiko Dvalishvili. Professor Dvalishvili, we are welcoming you here. Microphone is yours, yes. And she represents Tbilisi State Medical University kidney injury in patients with COVID-19. Please start.
Hello, everybody. First of all, thank you for this great opportunity to take part in this Congress. Today, I'm going to speak about the kidney injury in patients with COVID-19. I would start. As we all know, the COVID-19 has spread worldwide already, and it mainly targets the respiratory system and also the system of immunity. So it attacks the whole body. But today now we know that it affects not only the respiratory system, but also it affects on other organs of the body. It can be neurological, hepatic, gastrointestinal, thromboembolism, and other things maybe happen during the course of COVID-19. But today I'm going to speak about mostly about the renal syndromes. It is consists of the acute kidney injury, and also we have the proteinuria and hematuria, which was revealed in patients with COVID-19 in approximately 40%, and this is associated with the worst prognosis for the patients. There are some risk factors associated with COVID-19, with the AKI during the COVID-19, and it can be, for example, male gender, can be also some pre-existing long-term conditions, such as obesity, maybe diabetics, and of course it can be kidney injuries, for example, chronic kidney failure. These patients are at a very high risk of developing AKI during the COVID-19, and some mechanism can explain these things in patients. This can be, for example, direct cytotoxic effect, and there we have to mention ACE2 receptors and TMPRSS2, which are very important for the virus to penetrate into the cell and have the direct cytotoxic effect. Also, we have dysregulation of the RAS. Of course, there is endothelial cell damage because of the chronic inflammation and cytokine storms, of course. And we can mention there are other things that are very connected to each other, and these are very complicated to speak and takes a really long time, and I'm just gonna speak about it very briefly. We have other mechanisms here also. This is, for example, fluid management, mechanical ventilation, and nephrotoxins, which are used during the course of the COVID-19. Organ crosstalk, this is the lung and kidney crosstalk, and fever and sepsis or diarrhea during the COVID-19, which are connected to the hypovolemia and acute tubular injury. In my country, in Georgia, I'm very interested in nephrology, and when I found out that there was no researches in my country about the statistical data about the correlation of the COVID-19 and kidney injury, me and my professor, Marina Noniashvili, decided to make a little research about this. And this, the main of the study was to investigate the pathological changes in kidney function in the course of COVID-19 in patients who have never been diagnosed with kidney disease before and were hospitalized after at least 24 hours from the first symptoms of COVID-19. There is no need to discuss about the meaning of early detection. It's very important to find out when patient is going to have an AKI, because it gives us a very big therapeutic window to treat AKI, and it can prevent us from developing the chronization of the process. So AKI does not go to the chronic kidney failure. In this, to make sure the patient may have the AKI, we need some clinical studies. This is general analysis of urine, biochemical blood analysis, which consists of the creatinine and urea and sodium, potassium, chlorine, and others, and acid balance by base balance and kidney ultrasonography. I would say that these clinical studies, which are based on the creatinine and urea output and also eGFR, is not very effective because we have new biomarkers which are very good predictors of AKI, but unfortunately in Georgia and in many other countries, not only in Georgia, these biomarkers are not available to measure. So we only got this creatinine, specific gravity, and others I already mentioned. And it was a retrospective study. We collected and analyzed demographic information, underlying diseases, signs and symptoms, and laboratory data of 71 COVID-19 patients on the base of the first universally clinic database. All of them were hospitalized after at least 24 hours from the first symptoms of COVID-19. Patients were divided into 3 groups. Classically, it was mild, moderate, and severe group. Received data was statistically analyzed. We calculated the median, arithmetic mean, and standard deviation. The reliability of the difference between the data was estimated by the coefficient of reliability. Now it's interesting, very interesting, and what results we got. First of all, I'm going to start about results from the total number of the patients. We got that creatinine and urea was increased in the patients of from total number in 41 and 15%, and GFR was decreased in 57% of patients. We've got their hematuria, proteinuria, and leukocyturia in 64, 60, and 36% of patients. These are very high numbers, and it may be connected not only the COVID-19, but others factors too, which may not be mentioned in the medical history, because as I already mentioned, in these patients, none of them in their medical history had chronic kidney disease. It's interesting how the gender and age distribution looks according to the age and severity of the disease. We see that there is no important difference between the age of patients, but in the mild group we see the males number is much lower than females number. In other groups it's almost the same. As a result, I want to pay your attention to the chronic disease part. As I already mentioned, we have some risk factor that is associated to the AKI in COVID-19 cause, and one of them was diabetes. And as we see, along with the severity of the disease, the number of the patients with diabetic increases. Also, we got here hypertension and some congestive and coronary heart disease, in which and in these patients, the risk of this COVID-19 course is increased. About the creatinine and urea, I'd say that the same is happening here. Along with the severity of the disease, creatinine and urea level are increasing in patients, and eGFR decreases respectively. Specific gravity must be mentioned, of course, because it shows decreasing of the specific gravity shows the deterioration of the concentration function of the kidneys, and you see that along with the severity of the disease, the specific gravity decreases. Of course, we've got the proteinuria, leukocyturia, and hematuria, as I already mentioned. And received information indicates the alteration kidney function due to the COVID infection. Kidney function disorders increases in the correlation with the severity of the disease, and it is necessary to monitor kidney function in patients who have a mild clinical course of COVID-19, because there are some cases when there is no risk factor at all, but kidney injury still occurs, and it is a global problem, because as we all know, the chronic kidney disease is a global problem. It decreased everything for person. For example, their lifestyle, they cannot, for example, move, study, or do their things, and also it increases the mortality in populations. As a recommendation, early detection of damage, active monitoring of kidney functions, correction of its function, and adequate hemodynamic measurements and limitation of nephrotoxin drugs improve the prognosis of patients with COVID-19. And it is also necessary to determine new biomarkers of kidney damage to develop an optimal strategies for modern treatment. These biomarkers, most used biomarkers are NGAL, also KIM1, and we microRNA 21, which is the most evident microRNA in the human body, and they are very strong indicators for the AKI, and they prevent us from developing the first of all AKI and then chronic kidney failure. And if it would be great if in every country would be possible to measure these biomarkers, because this would be a great step forward in the nephrology. Thank you.
Thank you very much. And we move to the next presentation. And the next presentation is about experience with the use of ruxolitinib in the treatment of obliterating bronchiolitis in adult patients after allogeneic hematopoietic stem cell transplantation. Ruxolitinib. This presentation will be made by Dr. Kulagin from St. Petersburg. You're welcome. Good afternoon. Thank you very much. Please confirm you can hear and you can see me. Today we will speak about the experience of treating patients. We cannot see your slides. That's a remark from technical support. Just a second. So whilst we are introducing the presentation, I would like to draw your attention that we now move to so-called genetic strategy of treatment, and we fully understand that the use of transplantation is extremely important in this context. Please select the screen and PowerPoint on a specific screen. So that's a recommendation of tech support group. We are waiting for the slides to come. We're still struggling with slides. We speak a lot today about allogenic transplantation. As we all know, stem cells are new options for the treatment of chronic diseases. We are waiting for the slides to come. Please confirm you can see the slides. Negative. Negative. We are off the air. So we saw the slides just a second ago. Please make it full screen. Thank you very much. Now it's full screen. Just a second, we are off the air. We will start from the moderator, from Professor Fomin, and then we will give the floor to the speaker. So you can represent the title of the presentation once again. So please, 5 seconds, count down. 3, 2, 1. So, dear colleagues, we move to the next presentation. Extremely interesting presentation. Experience of the use of ruxolitinib in the treatment of obliterating bronchitis in adult patients after allogeneic hematopoietic stem cell transplantation. So, patients after transplantation with obliterating bronchitis and the use of ruxolitinib. Thank you very much for the introduction. So the treatment of obliterating bronchiolitis in patients after transplantation. What is obliterating bronchiolitis? Chronic disease of lower compartment, which is characterized with the inflammation of bronchioles, leading to partial or complete obstruction, obliteration with the progression of fibrosis. This disease can have multiple complications, but currently we speak about the type of GHVD, graft versus host disease, which is a complication after the allogeneic transplantation. And definitely it's an option to treat multiple malignant diseases. Pathogenesis is quite complicated. We see that epithelium is damaged in patients, recipients of hematopoietic cells after transplantation. At the same time, we see the remodeling plus fibrosis progressing and chronic inflammation that thickens the bronchial tree wall. There is worsening of the wall becomes more stiff, rigid. Then we see deterioration of dynamics and laminar function of bronchi that leads to the progressive of failure. Here you see the consensus criteria of National Institute of Health, NIHCC, United States. Criteria of bronchiolitis. You see, we should look at Tifno index, which is the ratio between FEV1 and FEV. Then features of bronchial obstruction, which is important using CT high resolution. And depending on the severity, it will be mild, moderate, or severe form of bronchiolitis. So we analyzed patients who had allogeneic transplantation for 13 years, from 2008 to 2021, acute leukemias, anaplastic anemias, etc., other baseline diseases, and they all had GVHD and chronic obliterating bronchiolitis. We analyzed the efficacy of treatment using ruxolitinib and the control group that got standard treatment, which got mTOR inhibitors, steroid hormones, and other options of non-specific treatment. As you can appreciate on the slide, from the clinical and functional outcomes, we see differences. Unfortunately, what is a serious problem that there is no standard of treatment which is not available. So mainly we speak about selection of treatment by test and trial. We used inhaled, then farm-like treatment, which is montelukast, and other options of inhaled steroid hormones in combinations with tacrolimus, sirolimus, MMF, systemic steroids, definitely inhibitors of calcineurin, imatinib, dasatinib, hormones, ibrutinib, and starting from 2016, we more and more frequently using of inhibitors. So that's the result. Mainly, we used ruxolitinib, and it led to the stabilization in 53% of the patients. Some patients have improvement of FEV1, 10% or more, and the progression is a reduction of FEV1, which was reported in 29% of the patients. The group of stabilization and partial response was much bigger versus progression. If you look at the control group, the response rate was much lower, but mainly that was stabilization. We don't see any statistical significance in between different groups, in between different options of treatment. You can appreciate using NIH and MMRC scales. That's the ruxolitinib response rate. In the active and control group, we see that ruxolitinib use allows to have lower demand to steroid hormones. We reduce them twice, which is a very, very preferable because patients reduces the risks of infections and other systemic manifestations related to steroid osteoporosis, steroid diabetes, Cushing's syndrome, hypertension, etc. So that's a very minimal experience. And we continue following our patients because that complication is quite delayed and could be quite severe. So it's very difficult to predict it. And definitely there are multiple challenges. We need to identify it early enough and preferably have specific treatment on that. All those who are dealing with the diagnosis and treatment of these patients, we all know how difficult it is. So I would like to gratitude Professor Afanasyev, who suddenly passed away, but it was he who attracted our attention to this challenge. So we continue fighting with this complication and proceed with our treatments. Thank you very much. Thank you very much, Yegor. I have a very short question. When do you think the symptoms will improve of bronchiolitis with the specific treatment? What is your suggestion? Well, the question is short and very difficult. Only quite recently, we got proper diagnostic options because until now, we didn't have any criteria. Only recently, we know how to make the diagnosis. Respiratory failure, they died from infections, and we looked at them morphologically. So hopefully new options of targeted treatment are coming, and hopefully these inhibitors could play a big role. Also ROC inhibitors, also ibrutinib. So possibly these options within the next 5 years will help us to treat and cure this complication. We are strongly hoping for that. Thank you very much. And we are moving to the next presentation. Bacterial infections in patients with liver cirrhosis and GI bleedings. This presentation is done by Dmitry Gavrilenko from Belarus, Gomel. Thank you very much, colleagues. Thank you for the opportunity to join this session and enjoy the Congress. I am extremely honored to make my presentation on bacterial infections in patients with liver cirrhosis and GI bleeds. Epidemiology is very well known. That's a common challenge. Mainly the bleed happens from the upper compartment of GI, which could be split in between varicose and non-varicose. And let me skip the structure and the rate, which are shown here from the results of the national and international studies. Bacterial infections, generally in the cirrhotic population, we see that about 1/3 are hospitalized patients after the administration to the hospital. If we take bacterial infection rates in patients with cirrhosis and developing bleed, so here the data are quite different, but about 45–50%. According to the literature, we see infectious complications in patients with complicated bleed. At the same time, we see some separate studies, very large studies, but not meta-analysis, where we see the prevalence of bacterial infections with bleeds much higher. It's almost 70%. At the same time, the investigators show that risks are increasing later, not at the moment of hospitalization, and only in 22%. These risks could be reported within the next 2 days. So that's a critical cutoff to distinguish in between the nosocomial and community-acquired infection. So infections is a one mechanism, and due to clear reasons, because these patients, they have normally many non-invasive procedures, less serious, more serious, but nevertheless, all that damages natural local barriers, and this is how patient goes to the risk group for the development of different infections. But on the other hand, bacterial infections could initiate the bleed per se. And this hypothesis was actively discussed for the last 20 years of the previous century, where the key role belonged to endotoxin, which is a component of cell wall of gram-negative gut bacteria, which are translocated in patients, especially in progressive decompensated liver cirrhosis. And already at the beginning of 2000, this theory got the confirmation. Well, first, it was proved in vitro, then in vivo, and the theory looks like this. If you sum up and shorten the mechanism in a nutshell, first of all, it's increase of intra-liver portal pressure due to the thromboxane and interleukin release, then increased varix size, and finally, that tension of the vascular wall cannot tolerate that, and that's a theory of burst, which is called this way in the English language literature. What could be the prevention of that? So there is a question. Patients with GI bleeds and liver cirrhosis, maybe they should be hospitalized in this situation. Or they already hospitalized. So what to do then? And the Cochrane collaboration demonstrates the results of large meta-analysis. The recommendation is clear. These patients should get antibiotic prevention treatment, AB prevention. But at the same time, they do not mention which population of the patients should get AB prevention. And there is another important moment. Here we see clear recommendations in between different groups of antimicrobials, which are recommended to use without any focus on local resistance, and definitely we get positive results, and this is meta-analysis data. So bacterial infection rate is reduced by 10-20%, control is improved, relapses of bleeds are prevented, so that improves the survival of patients with liver cirrhosis. And I emphasize once again, this is without the accent on heterogeneity of the patient group. What we try to do in this case, we had great opportunity to have retrospective analysis of medical records of the patients who died in Gomel and Gomel region with a diagnosis of liver cirrhosis and who had post-mortem study autopsies. This is how we got section data of 308 passed away patients. The median of age was 53. The liver cirrhosis was made based on macro and micro morphological features, keeping in mind the clinical data as well. The severity was assessed traditionally according to Child-Pugh. In some of the patients, due to the very short hospitalization, it was not possible to stratify severity because of absence of all parameters. But in majority of patients, which is 85%, that was class C by Child-Pugh. And this is quite clear. These patients had decompensated liver cirrhosis. Etiology is shown here on the slide. As you can appreciate, what we frequently see in national studies, the dominating reason is alcohol-based. In 1/3 of the patients, we cannot clarify. So this is heterogenic. Speaking about complications, 40% had different infections complications. Some of the patients had combined options. So total number of reported was 186. The structure looked quite traditionally, because here the leading position was taken by pneumonia and urinary tract infections. And also please appreciate the cases of spontaneous bacterial peritonitis that's quite unique for liver cirrhosis, and also cases of sepsis and soft tissue infections. Here on the chart, you could look at the structure of the bleeds. In majority of the patients, they were bleeds from varices of the esophagus, and also there were rare localizations shown here. Then we split patients into two groups, group with and without bleeds, where we try to compare them according to key parameters. The accent was made on the infections episodes, and they were shown a bit different picture. It appeared to be that in patients with bleeds, the infection rate was lower versus those patients who were bleed rates. That contradicted literature data, but we clearly know when we set an objective here, we had clear understanding that that's a very special group of the patients. We took patients with a decompensated liver cirrhosis, and the only parameter which was identified after the analysis of the patients is the duration being in the hospital, because those who were in hospital were shorter time versus patients who are bleed-free. Patients with bleeds were hospitalized for longer period of time. So this is hazard ratio. That's the most important. That's the biggest focus. We split patients according to the length of hospitalizations in days. Key periods up to 2 days or more, or 7 days or more. So these are the thresholds. And here at the bottom is something that I showed before. These are patients with bleeds with no risk of infections, although the culmination of this comparison are the following two groups. So these are patients who were hospitalized that less than 2 days after the bleeds or more than 7 days. These are tails of the curve. So that means prolonged hospitalization increases the risk of infection complication almost 10 times, So when we speak about specific recommendations and antibiotic prevention, mainly we should be guided by the clear clinical situation, but not go blindly, let's say, without following the recommendations of meta-analysis. So antibiotic prevention in GI bleed should be based on the clinical situation first, on the severity of the bleed, on the duration of hospitalization of the patients. We should be guided by that. And the key thing is the selection of antimicrobial treatment, because definitely it should be done after the assessment of antibiotic resistance, not only the hospital itself, but specific ward. And with that, thank you very much for your attention. Thank you very much, Dmitry. I have a question. 0.3% of the patients that was medically associated cirrhosis. So which medications were the priorities here? Thank you very much for the question. So there were two patients where from the medical history, we know the long administration of NSAID because of joint syndrome, non-steroid anti-inflammatory treatment. That's a rare situation when we have this link. But also that was also anatomical definition. So that was anatomical. Yes, I agree, but logically, you're right. Now we move to the next presentation. And we will speak about the elevated IL-6 levels in the long-term prognosis in elderly and senile patients with CHF and anemia and without anemia. And this is a group of authors, Dr. Solomachina and Dr. Dementieva. So IL-6, senile and elderly patients. Please activate your microphone. Thank you very much. Good morning and good afternoon, dear colleagues. We're happy to speak about the elevated IL-6 levels and the long-term prognosis in elderly and senile patients with CHF with and without anemia. And it was carried out in Sechenov University. It is very well known that CHF is one of the prevalent conditions among cardiovascular diseases, especially in economically developed countries where the rate is 1 to 2%, and in a Russian population it's even higher. The CHF rate is increasing due to aging of the population and increased life expectancy. It is very well known in patients who are elderly and senile. We see multiple comorbidities, and this comorbidity could prevail. One of the factors that is worsening the CHF and prognosis is anemia. And anemia rate in CHF patients varies from 30 to 58% and sometimes up to 79%, depending on the severity of CHF and anemia criteria. According to the data of large international study, anemia in CHF patients associated with a high functional class and high level of NT-proBNP that increases the risks of cardiovascular events, reduces the survival, and increases the mortality, and correspondingly worsens the prognosis. So anemia is independent factor of unfavorable prognosis. But if patients with and without anemia, the CHF prognosis is different, probably we should look for a biomarker that could make CHF and anemia more effective and more precise long-term and short-term prognosis. The general marker for CHF is definitely BNP, brain natriuretic peptide, and anti-proBNP, which is an amino terminal fragment. The role of other markers, specifically IL-6, is understudied. At the same time, IL-6 is one of the most important pro-inflammatory cytokine that plays a big role in pathogenesis of CHF, especially in case of decompensation. Also, increased level of IL-6 could be seen in anemia of chronic diseases, which are identified with CHF patients, and increased level of IL-6 could increase level of hepcidin and erythropoietin activity, which is reduced. And there are no studies in assessment of IL-6 in the senile and elderly patients. This data is scarce. These patients are rarely included into the studies, but the increased level of IL-6 and influence of IL-6 to the mortality rate and long-term prognosis in elderly and senile patients with and without anemia are quite contradictory. The objective of the study is to compare the mortality rate during 24 months of follow-up after the decompensation in CHF elderly and senile patients with and without anemia, and to study the influence of IL-6 to the mortality rate, IL-6 and mortality rate. According to the objective, we recruited 145 patients with CHF, elderly and senile, age 65-97, hospitalized with CHF, 105 with anemia, 40 without anemia. Control group, 30 patients without CHF, without anemia. All patients meet clinical portrait of CHF severity, was assessed by NIHA. Anemia was diagnosed according to WHO criteria. Inclusion criteria: age 65 plus, CHF decompensation, hemoglobin less 12 gram per deciliter if there is no blood loss proved, and CHF without anemia, hemoglobin higher than 12 gram per deciliter. Exclusion criteria: acute or chronic blood loss, oncological autoimmune diseases, anemia, aplastic, megaloblastic, hemolytic. IL-6 and anti-proBNP were studied by tests. Design: those patients who were hospitalized because of CHF hospitalization were selected to groups with and without anemia with CHF. Upon administration, we took blood for the standard assessment and identification of IL-6 and anti-proBNP. Then, patients were followed up to 24 months after the discharge. Primary endpoint was mortality, both from cardiovascular and non-cardiovascular reasons. Statistical analysis was carried out using software Statistica 8, using parametric and non-parametric methods of studies. Survival was assessed by Kaplan-Meier method. The influence of IL-6, we carried out regressional analysis of proportional risks by Cox. Difference was statistically significant with p less than 0.5. All patients had very similar characteristics in age, gender, and severity of CHF. We identify high cardiac and non-cardiac comorbidities, differences in the rate of MI and pneumonia rate. According to the data we have received, the level of IL-6 with CHF with anemia was much higher than IL-6 without anemia and versus control group. Within 24 months in the both groups, 86 from 145 died. That means more than 159% with anemia, 59% without anemia, 40% rate. Mainly mortality reason is progressive CHF and 22.5%. Cardiovascular reasons and non-cardiovascular 8.6 and 5% correspondingly. Looking at Kaplan-Meier, we see that in groups with and without anemia, we see higher mortality rates starting from month 4. And by month 24, the difference becomes statistically significant. One-factor regression Cox analysis in CHF with anemia identified significant influence of IL-6 to the mortality rate, and in group CHF without anemia, the influence was not important. So patients, elderly and senile, CHF and anemia and increased IL-6, the long-term prognosis after the compensation of CHF is much worse versus patients with CHF without anemia. Higher mortality rate, both cardiac and non-cardiac reason, was reported in patients with CHF and anemia versus CHF without anemia in prospective follow-up within 24 months after decompensation due to the decompensation of CHF could be explained by inflammation, and high level of IL-6 confirms that and the influence of IL-6 to the mortality rates. Thank you very much for your attention. Thank you very much. Thank you very much, Anna. I have a very short question. IL-6, is it possible to use it to confirm the severity of condition in CHF patients, or do we need anemia as a must? Well, in case of anemia, IL-6 will be high. Yes, I understand, but do you recommend to measure IL-6? I'm speaking about IL-6 as a prognostic factor. Could be used, or still NT-proBNP should be used as a criteria. I think we can, but routinely IL-6 is quite expensive. Yes, I agree, Anna. Well, 10 years ago, we even could not imagine that we can measure NT-proBNP, but now we do it almost everywhere. And now we move to the final presentation. The use of felodipine in the treatment of bevacizumab-induced arterial hypertension, felodipine. This presentation would be made by Dr. Khlyamov from Kursk. Good morning and good afternoon, dear colleagues. Thank you very much for the opportunity to speak at such a high-level conference and present Kursk State Medical University. So my topic is quite relevant because we know that arterial hypertension is a very frequent cardiotoxic of anti-VEGF agents that could observe in 35% of the patients getting bevacizumab, which is a humanized monoclonal anti-IgE1 antibody to the vascular endothelial growth factor, VEGF. The objective of the project was to identify the efficacy of felodipine for the treatment of hypertension associated to bevacizumab in the group of oncology patients. So methods we used, shown here. This is mainly retrospective review of electronic databases, medical records of the patients who were treated by bevacizumab in the Kursk State Center. Also, inclusion criteria here was the metastatic cancer that required chemotherapy based on bevacizumab. We also use descriptive statistics in this case for the analysis of patients' characteristics, such parameters that average levels 95% confidential interval, and also we assessed for the comparison methods of He quadrant and Fisher criteria, and P were bilateral and considered to be statistical with the level of P005. Classification of cardiotoxicity was identified according to the common terminology criteria for adverse events from the National Institute of Health of the United States, version 5. And this classification is presented here on a particular slide, and let me skip that, please. And also cardiotoxicity was identified according to more standard classification of arterial hypertension by European Society of Cardiology, which is presented on a specific slide. So the types of cancer that were considered, that's colorectal cancer. At the same time, the treatment was used with 5-FU using bevacizumab. And also it could be a group of patients with non-small cell lung cancer or ovarian cancer that were treated by platinum-based chemotherapy with the use of bevacizumab additionally. The results of the study shown here, intergender ratio, females were prevailing, which was 52.4%, although I think gender ratio was more or less similar in our sampling. Arterial hypertension in the medical history was assessed by medical records. Mainly, they did not have any arterial hypertension in the previous medical history, which is 74% of the patients. We also assessed the development of hypertension after the use of bevacizumab according to the scale CTCAE and ESC. Arterial hypertension grade 1 to 3 was reported in 45.5% of the patients by CT-CAE, and according to the scales of European Society patients, that was 41% of the recruited. Let's appreciate antihypertensive treatment which was administered. In case of acquired hypertension with bevacizumab, mainly felodipine was used, 56.5%. If hypertension or other cardiovascular disease already established in the medical history before bevacizumab, then the following combinations were used. And if hypertension was diagnosed long ago, then there were many combinations of beta blockers with felodipine. And in majority of the patients, almost 22%, or it could be felodipine with ACE inhibitor, azinapril. The other option, it could be some other cardiovascular disease in the medical history, then it was beta blockers, plus 13% alecanidipine. What are the results of arterial hypertension? After the use of felodipine in the dose of 5 milligram in group A, where we observed hypertension developments in the administration of bevacizumab, we reached 140 by 90 millimeters in 88% of the patients. Then in 7.7% of the patients, after the first week of antihypertensive treatment, we had to increase felodipine dose up to 10 milligram. And almost in 4% of the patients, we added fosinapril to felodipine in the dose of 2.5 milligram fosinapril. And in two latter categories, the high blood pressure was normalized within 1 week. In group B, those patients who already had arterial hypertension or other cardiovascular disease at the baseline level, the normalization of blood pressure 1 week after the start of antihypertensive treatment was reported in 85% of patients, combination beta blockers plus felodipine. And in 20%, after the first week of antihypertensive treatment, arterial blood pressure was not stabilized with this double combination. And as a result, fosinapril was added. And then after 1 week, arterial hypertension was properly controlled. What conclusions could be made here? We proved the efficacy of using dihydropyridine beta calcium channel blocker felodipine in the treatment of bevacizumab-induced arterial hypertension as a monotherapy at a recommended onset site, and also at a maximum dose in combination with ACE inhibitors. We also confirmed the efficacy of using calcium channel blocker felodipine in patients who were getting treatments anti-VEGF like bevacizumab, and also we should keep in mind that non-dihydropyridine calcium channel blockers like verapamil and diltiazem are the inhibitors of cytochrome P3A4, and nifedipine, which is dihydropyridine calcium channel blocker, could induce the secretion of VEGF. With that, thank you very much for your attention. Thank you very much. I have a question to ask. Please share bevacizumab-induced hypertension. I think is it easier or more difficult control by antihypertensives? And we have to increase the doses and to be more aggressive in our treatment, or maybe to use a higher rate of combined treatment. Thank you very much for the question. Bevacizumab-induced arterial hypertension is quite complicated disease because currently we have no clinically significant and clinically approved schemes of treatment. There are different clinical recommendations, different approaches, Eurasian and European Society of Cardiologists, but again, there is no clear algorithm, there is no clear scheme like it's diabetes-associated arterial hypertension or combined with ischemic heart disease, or combined with atrial fibrillation. So there is no clear guidelines, no clear standards, and that's the challenge. And that's the biggest interest, to try to design relatively sustainable scheme of how to use antihypertensives and which antihypertensives for the treatment of bevacizumab-induced hypertension. Yes, I got it. Absolutely, absolutely, because currently we have recommendations for the blood pressure control. The question is, the increase of the pressure, is it easy to control or more difficult to control versus classical arterial hypertension, which is not associated with bevacizumab, which is not induced by anti-tumor treatment? The reduction of arterial blood pressure could be reached relatively similar to the other pathologies. So the biggest challenge here is to select proper effective combination. And here is a question: what to select, what to do? Thank you very much. Thank you very much, distinguished colleagues. With that, we wrap up our session, late breaking science. And today we were speaking about very different pathologies. We were speaking about cardiology, in pulmonology, and also gastroenterology, etc., etc. So we spoke even about COVID. So with that, dear colleagues, we fully understand how diverse could be the late breaking science news. So this dialogue is very important. We should look at Russian, national, European, American guidelines for the treatment of different pathologies. Now we are stepping away from that because we have new definitions, new options, new information is coming, which is requiring totally different approaches. That is why our distinguished speakers brilliantly demonstrated that we need to identify these modern approaches, and very soon, within 2, 3, 5 years, that will be part of national guidelines. Thank you very much. We wish you all the best. Be happy and be healthy, and hopefully this session would be continued. Thank you very much and enjoy the break. Next symposium, depressions in chronic diseases.